Good morning, and welcome to the virtual conference, A New Normal. My name is Brian Emerson. I have the honor of presenting on the characteristics of group sex events among U.S. men who have sex with men reporting in the American Men's Internet Survey. Why is group sex important? Well, literature suggests that 1/4 of men who have sex with men engage in group sex. This behavior also provides opportunity for HIV and STI transmission from one infected individual to 2 or more partners in one sexual encounter. Group sex could also increase the population level transmission rate if the infected person has a path to a larger sexual network. Although group sex is not new, literature is limited on their sexual behaviors and the uptake of HIV and STI prevention methods. Our objective was to better understand the prevalence, characteristics, and HIV and STI prevention services among HIV-negative gay, bisexual, and other men who have sex with men, MSM, who engage in group sex events. The methods. Well, one national survey does contain questions about if a male participated in group sex events, GSE, in the past 12 months. The American Men's Internet Survey, AMIS, is an annual survey administered by Emory University. The focus of the survey is to add knowledge about the risk for STI and HIV, clinical and sexual behaviors in sexually active gay, bisexual, and other men who have sex with men in the United States. During the 2018 AMIS cycle, men were recruited and could participate if they reside within the United States and are 15 years of age or older. Adult consent was required for participants before they could complete the survey. The requirement did not depend on HIV status and focused on reaching the men on various social media platforms. And if you look at the right of the slide, you will see an actual banner from one of the recruitment activities. Convenient sampling methodology was used during data collection. In 2018, 10,259 surveys were completed. These included sexually active males 15 or older, both HIV positive or HIV negative men. For our analysis, we subsetted the original dataset, excluding anyone HIV positive and younger than 18 years of age, using SAS 9.4. We wanted to make sure we were able to analyze the testing frequency of HIV, so we excluded the HIV positive men and wanted to stay consistent with other literature and only analyze adults 18 or older. The exclusion criteria left us up with a data set of 8,784 completed surveys from HIV-negative men 18 or older. We defined group sex events as 2 or more sexual partners during one sexual encounter. As I stated in our objective, we analyzed prevalence, characteristics, and use of HIV and STI prevention services within the subsetted cohort. The results. As you can see in the pie chart, 29%, 2,578 of the MSM reported at least one group sex event in the past 12 months. That's almost 1 in 3. And with those men reporting group sex, 69% reported more than one group sex event in the past 12 months, with a median of 2 and an IQR of 1 to 5. And even breaking this down a little further, group sex engaging with 2 partners, threesomes, were reported approximately 26% of the time, and group sex events involving 2 or more partners, more than 2, were reported 12% of the men reporting group sex events. Now we're only looking at the men who participated in at least one group sex event in the past 12 months. I know there's a lot on this table, but I will separate the sexual behaviors and testing and prevention options down on the next couple of slides, highlighting the results for each behavior on the table. Up to 2,578 reporting at least one group sex event, 5% reported only oral sex, and 95%, 2,444, reported anal sex. Up to 2,444 men reporting anal sex, 2,067, 85%, also reported engaging in condomless anal sex. Of the men reporting engaging in condomless anal sex, 67% of those, 1,388, reported condomless anal sex and did not report uptake of HIV pre-exposure prophylaxis PrEP in the past 12 months. Of the men engaging in group sex event in the past 12 months, approximately 25% were not tested for HIV, that's 1 in 5, and approximately 41% were not tested for an STI. That is 2 in 5 of people having group sex received an STI test. Remember, 85 of those people reported condomless anal sex, and 67% of those people were not currently taking PrEP. Limitations should be noted. First, the study is not generalizable to all MSM due to multiple factors. Internet recruitment and convenient sampling approach created response bias to only men who have access and visit websites to complete the survey. Second, the sample contained a high proportion of white non-Hispanic men and a small proportion of Black and African American men. Third, all behaviors are self-reported for the past 12 months, possibly creating recall bias. In conclusion, about 29% engaged in group sex with a median of only 2 events in the past 12 months, which is a small number of men engaging in group sex are engaging group sex at a high frequency. Yet the STI screening rates are below optimal and leaves paths for exposure. If you're expecting to reduce the morbidity of HIV and STIs, then tailored education, outreach, and increased testing events is needed for the subpopulation. In future research, I would like to take a closer look into the individual and population level risks for this subpopulation against MSM who do not engage in group sex. As noted on the slide, group sex has been a public health concern since the 1980s, and 40 years later, a greater understanding is still needed in 2020. A little disclaimer that the findings and conclusions do not represent the official position of Centers, Disease Control, and Prevention. Thank you for your time. There will be questions during the live conference, and I have my contact information up currently if you'd like to reach out and ask additional questions.
Hello, my name is Christine Kazrapor. I'm from the University of Washington, and I'll be talking about changing patterns of sexual behavior and STI risk among MSM in Seattle. I'd like to start by thanking the conference organizers for inviting me to record this talk, and would like to acknowledge my co-author, shown here on the first slide. So for decades, MSM have modified sexual behavior to reduce the risk of HIV transmission and acquisition. An example of one of these behaviors is serosorting, defined as limiting sex partners or limiting condomless anal sex partners to only those with concordant HIV status. A meta-analysis published a few years ago found that serosorting is associated with a lower risk of HIV acquisition relative to condomless anal sex with serodiscordant partners, but a higher risk relative to consistent condom use or no anal sex. But notably, most of the studies, including this meta-analysis, had collected data in the early 2000s. So with the increase of biomedical prevention strategies for HIV prevention, this may have modified the frequency of these behavioral HIV prevention strategies. And some have hypothesized that the increases in STI rates in the US may be partially due to changes in sexual behavior in the contemporary HIV prevention era. So the objectives of this analysis were to describe changes in reported sexual behaviors among MSM from 2002 to 2018, and to estimate the risk of STI and change in the risk of STI over time for different behavioral HIV prevention strategies. So we used routine clinic data from the Public Health Seattle and King County Sexual Health Clinic from 2002 to 2018. At the Sexual Health Clinic, patients complete a clinical intake that queries them on their sexual behaviors in the past 12 months, among other things. Before 2010, this was a face-to-face interview with a clinician. Since 2010, this has been a computer-assisted self-interview. HIV and STI testing is conducted at the sexual health clinic per standard clinic protocol following CDC guidelines. And in this analysis, we included clinic visits for cisgender men who reported sex with a man in the last 12 months. We created 4 mutually exclusive categories of behaviors based on reported sexual behaviors in the last 12 months. The first was serodiscordant condomless anal sex, or CAS, defined as inconsistent condom use with HIV serodiscordant or unknown status anal sex partners. Second was CAS exclusively with seroconcordant partners. This is consistent with the definition of serosorting, defined as inconsistent condom use only with HIV seroconcordant anal sex partners. Third was men who reported consistent condom use with all partners, regardless of HIV status of their partner. And fourth was men who reported no anal sex. So for analysis looking at behavioral trends over time, we report the proportion of MSM reporting each behavior for each year of the analysis. We included only a patient's first visit to the clinic in a given year. For analysis looking at the risk of HIV and STI for different behavioral strategies, we had 3 outcomes: HIV, early syphilis, defined as primary, secondary, and early latent, and rectal gonorrhea and chlamydia. We used log binomial regression models with robust standard errors to estimate relative risks and 95% confidence intervals. We used the clinic visit as the unit of analysis. And for the purposes of this presentation, I'll be sharing one comparison, and that's comparing MSM who reported CAS with serodiscordant partners to MSM who reported CAS only with seroconcordant partners. So that's those first 2 behavioral categories on the previous slide. And we used an interaction term for a year to test for changes in the relative risk over time. So during the study period, there were over 62,000 visits by MSM to the sexual health clinic in Seattle. About 85% of those visits had complete behavioral data and were included in the analysis. Those visits comprised 33,000 unique MSM without HIV and 5,000 unique MSM living with HIV. On the right of the slide is some select characteristics of our study population at the level of the clinic visit. So about 33 to 60% of MSM in our study population were less than 35 years old. 11% were Latinx ethnicity. About 60% were white race, which is consistent with the demographics of Seattle and King County. About 50% of men had reported more than 5 sex partners in the last year, and about a third of MSM living with HIV and 13% of MSM without HIV reported ever using methamphetamine. So I'll be showing a series of graphs on the next 2 slides. So I'll take some time to orient you to these graphs. On the y-axis is the percent reporting one of the 4 categories of behaviors. The orange line represents MSM living with HIV. The blue line is MSM without HIV. All graphs have a break between 2010 and 2011 as a reminder that is the time point at which we switched data collection method from a face-to-face interview to a computer-assisted interview. So the graph on the left shows the proportion of MSM reporting condomless anal sex with serodiscordant partners. And what you can see is that reporting of that behavior declined from 2002 to 2010, remained relatively stable the next few years, and then we saw pretty substantial increases in reporting this behavior among MSM living with HIV and also increases among MSM without HIV. On the right-hand side is condomless anal sex exclusively with seroconcordant partners or serosorting. For MSM without HIV, we've seen increases in reporting this behavior over the entire study period, whereas for MSM living with HIV in the orange line, we saw increases in serosorting up till about 2010, followed by substantial declines through 2018. For both consistent condom use with all partners and no anal sex, we saw pretty steady declines in reporting these behaviors among all MSM throughout the entire study period. Moving on to looking at trends in HIV and STI test positivity, on the left-hand side is test positivity of HIV-STI among MSM without HIV. And looking at the blue line, which represents test positivity for HIV, what you can see is that the test positivity for HIV declined substantially from 3.7% in 2002 down to 0.5% in 2018. Concurrently, we saw increases in test positivity for both early syphilis in the orange line and rectal gonorrhea and chlamydia in the green line. On the right-hand slide is test positivity for MSM living with HIV, and for both early syphilis and rectal gonorrhea and chlamydia, we saw pretty overall increases in both of these infections, the diagnosis of both of these infections over the study period. These forest plots show the relative risks for HIV or STI for MSM reporting CAS with serodiscordant partners relative to MSM reporting CAS only with seroconcordant partners. The dashed line at 1 represents a null association. These are relative risks and 95% confidence intervals. On the left-hand side is MSM without HIV. And what you can see is that for MSM reporting CAS with serodiscordant partners, they had an 85% higher risk of HIV relative to MSM reporting CAS only with seroconcordant partners or serosorting. For early syphilis, there was about a 40% higher risk. And rectal gonorrhea chlamydia, there was about a 7% higher risk, and it was marginally statistically significant. On the right-hand side is the data for MSM living with HIV, and we didn't note any significant associations in the risk of early syphilis or rectal gonorrhea and chlamydia comparing these two populations of men engaging in these behaviors. And in testing for interaction by year, we did not have any statistical evidence for effect modification by year. So in other words, the relative risks shown here did not significantly differ from year to year in our study period of 2002 to 2018. So in summary, since 2010, CAS with serodiscordant partners has increased substantially following a nearly 10-year decline. And this shift in behavior may have contributed to population increases in STI incidence concurrent with decreasing HIV incidence. Among MSM without HIV, the risk of STI was higher for individuals reporting CAS, serodiscordant CAS, compared to those reporting only seroconcordant partners, and this risk did not change appreciably over time. So we have 3 primary limitations of this analysis. First, these data are from a single clinical site in Seattle and likely not widely generalizable outside our study population or outside Seattle. Second, our analysis did not stratify by patient PrEP use or reported partners, antiretroviral therapy use, or PrEP use because of some inconsistencies in how these data were collected during the study period. And third, our test for interaction examined sort of average changes over the study period and would not have picked up smaller changes that occurred in individual relative risks from year to year. So in conclusion, the shift in population behavior reaffirms the need for routine STI screening and also biomedical strategies to prevent STI. And these changes in behavior that we noted were likely the result of informed sexual decision-making, such as choosing partners based on their own or their partner's antiretroviral therapy or PrEP use. And this highlights the need for the promotion of a candid discussion between medical providers and MSM patients about behavioral strategies that mitigate both HIV and STI risk. So with that, I'd again like to acknowledge my co-authors who were shown on the first slide, acknowledge the patients at the Public Health Seattle County Sexual Health Clinic, and acknowledge the Sexual Health Clinic clinical providers, staff, and disease intervention specialists. Thank you for your attention.
I'm Jackie Jennings, and I'll be speaking with you today about meeting sex partners online, syphilis, HIV, and drugs among Black, gay, and bisexual men. I have no disclosures to report. Since 2001, the incidence rate of syphilis cases in the U.S. has increased nearly every year, with MSM accounting for the majority of new cases. The national prevalence of primary and secondary or PNS syphilis cases increased 413% from 2000 to 2017. In 2017, the CDC reported that men make up 90% of all PNS syphilis cases, and MSM comprise 82% of these cases. Baltimore City, Maryland has experienced one of the most extreme epidemics with a PNS syphilis rate 3.6-fold times higher than the national rate in 2017. The group most heavily affected by the syphilis epidemic in Baltimore is the Black MSM community. And from 2009 to 2015, Black MSM accounted for 53% of all reported early syphilis diagnoses in Baltimore. Importantly, Baltimore City also has among the highest levels of HIV prevalence in the nation, ranked 14th for HIV prevalence in 2016. So these epidemics are closely linked with one another. And this shows a chart of primary and secondary syphilis in Baltimore City from 2013 to 2017 among women, men who have sex with women, and MSM separately. And what you see is this great disparity showing that the majority of cases are experienced by MSM. Among MSM with PNS syphilis, approximately half are also diagnosed with HIV. Drug use, and specifically stimulant use, such as methamphetamine, has been found to be associated with STIs and HIV in other, and particularly other urban settings, but has not been found in Baltimore City to date. The consumption of stimulants to facilitate or enhance sexual experience has been called a myriad of things, but some of the most common terms are called chemsex, party and play, or P&P, and wired play. Methamphetamine is one of the most frequently used stimulants. In addition to drug use being associated with STI and HIV transmission, there's a growing body of evidence that suggests that sex partner meeting places may be important for transmission networks as well. They're also very important in terms of places to access high priority or high transmission networks and individuals. So when we talk about sex partner meeting places, we're talking about venues where individuals congregate. They can include physical spaces like bars and clubs, or internet apps, social websites, or even in Baltimore City, we still have a chat line. And the reason they're important, again, I mentioned, is access, but also because they may attract individuals with transmissible infections, so there may be variability in transmission across sites, which would be helpful to understand for targeting and prevention control. But they also may facilitate sex and drug use. Certainly there have been indicators and anecdotes in the literature that suggest that people have particular profiles on their apps that may suggest that they, for example, party and play, or listing party with a capital T, and those are indicators that somebody may be a methamphetamine user and may be interested in using methamphetamine and along with sex. So we sought to look at these sex partner meeting venues as well. So the objective of our analyses was to determine the association between methamphetamine use, sexual risk behaviors, sex partner meeting places, syphilis, and separately HIV positivity among Black MSM in one mid-Atlantic U.S. city without a known history of these associations. The data for this study came from the Understanding Sexual Health and Network Study, or USHINE, as we locally call it, which is part of a multi-site study called the Network Epidemiology of Syphilis Transmission, or NEST study. This is a 4-year CDC-funded study that is ongoing and started in April 2017. It's a prospective longitudinal cohort study, and it's examining syphilis and HIV transmission in sexual networks among MSM between the ages of 18 to 45. In Baltimore City, our recruitment sites included 3 clinical sites and 1 community-based organization. We used respondent recruitment from these sites, but also respondent-driven sampling from recruited participants, whereby enrolled participants were given 5 cards to give to social contacts. We conducted an audio computer self-assisted interview and an egocentric sexual network survey. We also conducted syphilis and HIV testing, and for the purposes of this analysis, syphilis infection was defined as a primary, secondary, or early latent infection, and HIV infection was defined as a positive HIV result. This study population includes 359 MSM enrolled at their baseline visit, and specifically 75% of those, or 268, who self-identified as Black MSM. The characteristics of this population include, on average, the men were 30 years of age. 52% reported greater than 3 sex partners in the past 3 months. 29% reported anonymous sex in the past month. 15% reported methamphetamine use. and looking at sex partner meeting places as potential access points for these men. 28% reported using Facebook in the past 3 months to meet sex partners, 26% reported Atom for Atom, 41% reported Grindr, and 59% reported using Jacked, all of them online sex partner meeting places. Then we looked at the associations between methamphetamine use, sexual risk behavior, specific sex partner meeting places, and syphilis and HIV positivity in this population. And what we found were that the men reporting methamphetamine use were more likely to have had greater than 3 sex partners, were also more likely, significantly more likely to report anonymous sex. They were more likely to have reported meeting sex partners at Jacked, Grindr, and Atom for Atom. And they were also more likely to be HIV positive. They were not more likely to be syphilis positive. And when I say more likely, I mean statistically significantly more likely. So from this, we also looked at associations between HIV positivity, syphilis positivity, given the syndemic nature and specific sex partner meeting places. And what we found was that HIV positivity and syphilis positivity were significantly related to one another, and that if you were HIV positive, you were more likely, significantly more likely to report meeting partners on Jacked and Atom for Atom. So then we were curious about this relationship between HIV and syphilis positivity and methamphetamine. We stratified the men into 4 groups according to their HIV and syphilis positivity status. So the first, what you see in the columns are HIV negative and syphilis negative, HIV negative, and then syphilis positive and onward. And then we looked at their self-reported methamphetamine use. And what we found, what you can see is really the first 2 columns, those men that were HIV negative, were much less likely to report methamphetamine use compared to those men that were HIV positive, regardless of their syphilis status. So this was interesting to us to help us understand better how this was playing out. So among the Black MSM, methamphetamine use was associated with HIV, also associated with specific sexual risk behaviors, and 3 online meeting spaces. And these are similar to findings in other urban settings. But methamphetamine use was not associated with syphilis infection. HIV positivity was also associated with co-infection with syphilis and with 2 online meeting spaces. In this locale, through speaking in focus groups with Black MSM, there were reports validating the increase in methamphetamine use, specifically increases noted since 2015. And our data suggests that specific online meeting places may be important access points for HIV and drug use prevention. Clearly, the racial disparities in number of new syphilis infections and the overlapping infections with HIV demonstrate that our current prevention strategies are not effective, and it really underscores the need to prioritize syndemic control strategies, particularly among MSM at great risk for transmission and acquisition. It's just a reminder, the strategies are most effective when they're implemented at the right time in the right place and space, which is why we really looked at sex partner meeting places as well, and with the most important populations, in this case suggesting that there's an important group of methamphetamine users that are at high risk here. And the evidence suggests that syphilis and HIV, this endemic, is complex and intertwined with an epidemic of stimulant drug use, and that issues of intersection. As always, it takes a village in this work, so there were many, many people that have collaborated on the UShine study, and also in a partners study, which is the CDC Pride and Thrive programs, which helped to fund our understanding of HIV epidemics among MSM. So I'd like to thank all my colleagues and all the partners that made this possible as well. And if you have any questions, please contact me. You'll see my contact information on the right lower hand corner. Thank you very much.
Hello, everyone, and thank you all for being here virtually. I'm Jessica Wagner, and I'll be reporting on racial differences in online dating app use, sexual network structure, and HIV serodiscordant mixing. And I have no financial disclosures to report. So in the United States, the HIV and syphilis epidemics disproportionately affect Black, gay, bisexual, and other men who have sex with men, which from this point on, I'll be referring to as MSM. For example, in 2016, MSM made up 67% of all new HIV diagnoses, the plurality of which were among Black MSM. In Baltimore City alone, a city in the mid-Atlantic region of the United States, Black MSM comprised the largest group, almost 30% of those living with HIV. Growing research indicates that sexual networks and their associated characteristics play a role in increased risk of HIV transmission among Black MSM. And use of online dating apps has significantly increased among MSM and may play an important role in network structure. And networks are important and may play a role because risk is subject not only to the individual's risk behaviors, but the risk behaviors of other partners in his sexual network. Additionally, the characteristics of a network, such as network density and partner concurrency, as well as network composition, may play a role in transmission risk. The objectives of this analysis were to first determine if patterns of use of online dating apps differ by race, and second, to examine the association between specific online dating app use and sexual network characteristics and stratified by race. Data for this analysis came from the UShine study, which is an ongoing prospective longitudinal cohort study examining syphilis transmission in sexual networks of MSM between the ages of 18 to 45. And UShine is part of the Network Epidemiology of Syphilis Transmission, or NEST study, which is a 4-year CDC-funded study that began in April of 2017. It includes 3 sites, Baltimore, Maryland, Columbus, Ohio, and Chicago, Illinois, and data presented here today will be from Baltimore. A study visit is comprised of 3 parts: STI testing for chlamydia, gonorrhea, syphilis, and HIV, an individual level socio-demographic ACASI survey, and an egocentric sexual network survey, in which participants are asked about their sex partners from the past 3 months, and then a more detailed subset of questions on their 3 most recent sexual partners. From the network data, we defined 3 outcomes: individual concurrency, which is an index that reports sex with multiple partners at the same time; sex partner concurrency, which is the index perception that the sex partner had sex with other people while having sex with them; and HIV serodiscordant partnerships, which is a dyad or partnership of a person living with HIV with an HIV negative or unknown partner, or vice versa. And we completed our statistical analysis by generating summary statistics and chi-squared tests or Fisher-exact tests and t-tests. 388 men in our study reported at least 1 sex partner. Of these, 75% were Black MSM and 25% were non-Black MSM. And these men reported on 868 sex partner dyads. And this represents the 3 most recent sex partners where we have the more detailed subset of questions answered. For our study population, the average age was around 30 years, and there was no difference in age by race. Non-Black MSM were significantly more likely to report a sexual identity of gay or homosexual exclusively. Black MSM were more likely to be a person living with HIV, and no differences were seen in the number of reported sex partners, which was around 5. Non-Black MSM were more likely to report using websites or dating apps to meet sex partners, and additionally were more likely to report any condomless anal sex in the past 3 months. This graph presents online dating app use among Black MSM and non-Black MSM. In blue, you can see the percent of Black MSM reporting use of a specific dating app, and in green, you see the percent of non-Black MSM. Along the x-axis, are the specific dating apps we looked at. An asterisk denotes a significant finding with a p-value of less than 0.05. We found that Black MSM reported significantly higher use of 4 apps: Facebook, Atom for Atom, Jacked, and Instagram, compared to non-Black MSM. Conversely, non-Black MSM reported significantly higher use of 3 apps, Grindr, Scruff, and Tinder, compared to Black MSM. Due to these differences in app use by race, we looked at sexual networks and dating app use stratified by race. Among Black MSM, we looked at the sexual network characteristics first at the participant level. So we first looked at sexual network size, which was measured by the reported number of sex partners in the past 3 months. Users of 2 apps, Grindr and Jacked, reported significantly more sex partners compared to non-users, and the greater sign denotes the direction. Next, we looked at any individual concurrency, which again is the index participant reporting that at the time of the partnership, the index was also having sex with other partners. And here we saw that of the 8 online dating apps, for 7 users reported significantly higher proportions of individual concurrency compared to non-users. And there were no significant differences in any condomless anal sex between users and non-users for any app. We next looked at sexual network characteristics among Black MSM at the partner dyad level. For sex partner concurrency, or the index's perception that the sex partner was having sex with other people at the same time, we found that 4 online dating apps, Facebook, Grindr, Jacked, and Kik, users reported more sex partner concurrency compared to non-users. For HIV serodiscordant partnerships, which is defined as one partner being a person living with HIV and the other partner being either HIV negative or having an unknown HIV status, for 2 apps, Jacked and Kik, users reported significantly more HIV serodiscordant partnerships compared to non-users. On the flip side, users of 2 apps, Instagram and Tinder, users reported significantly less serodiscordant partnerships compared to non-users. For non-Black MSM, 2 apps, Grindr and Scruff, app users reported significantly more sex partners compared to non-users. There were no significant differences in reported individual concurrency or any condomless anal sex. Among non-Black MSM, only use of 1 app, Kik, was associated with increased sex partner concurrency compared to non-users. Additionally, for only 1 app was there a significant association with HIV serodiscordant partnerships, with Grindr users reporting less serodiscordant partnerships compared to non-users. In summary, we found evidence of racially segregated online dating app use to meet sex partners. Among Black MSM, specific online apps were associated with increased individual and perceived sex partner concurrency, and were also associated with serodiscordant sex partnerships. In fact, 2 apps, Jacked and Kik, were associated with increases in all 3 measures. Importantly, the extent of these associations were not observed among non-Black MSM, with only 1 app being associated with perceived partner concurrency and a different app being associated with HIV serodiscordant partnerships. And while what we found is interesting in and of itself, our findings have implications for future research. Online dating app use may reflect and facilitate different sexual networks for Black MSM compared to non-Black MSM. As we saw among Black MSM, users of specific online apps have increased partner concurrency and increased individual concurrency and reported serodiscordant partnerships, which are 2 factors that are required for sustained HIV transmission within a sexual network. And this may contribute to racial disparities in HIV transmission risk. Future online and dating app-based interventions should account for these differences. And I would like to thank all of our study participants especially, as well as everyone else listed here who has worked on the study and helped with the study and helped with this analysis, as well as our partners and funding sources. And here is my email in case anyone would like to contact me with any questions. Thank you.
Hello, I am Rinda, and I'm going to talk about space-time clustering of syphilis among key populations in Baltimore City, Maryland between the years 2009 and 18. There has been an upsurge in the number of syphilis cases, especially among priority populations such as gay, bisexual, and men who have sex with men and commercial sex workers, hereon abbreviated as MSM and CSW, respectively. Now, our CSW populations includes both males and females. In order to aid public health resource interventions and control strategies, we have two objectives. One, to describe and quantify the spatiotemporal epidemiology of syphilis cases in Baltimore City. And second, to explore the extent to which the epidemiology suggests transmission overlap amongst these two priority populations. Public health surveillance data collected by the Baltimore City Health Department on primary, secondary, and early latent syphilis cases was used for this analysis. We investigated semi-annual temporal trends, annual spatial trends, and annual spatiotemporal trends in both of these populations using STATA, ArcMap, and SAT-scan. We looked for the occurrence of MSM and CSW syphilis cases by 6 months over the 10-year time period. We examined annual spatial trends in both of these populations by 1-year intervals of time. Also, we investigated the distribution and spread of the MSM and CSW cases geographically. We detected census tracts having high syphilis counts. And most importantly, we investigated if there was a significant overlap among these two priority populations, both geographically and temporally. Let us have a look at the definitions first. A census tract with high number of syphilis cases was defined as having 4 or more MSM syphilis cases or 3 or more CSW syphilis cases within a year over 3 or more consecutive years. Now, clustered census tracts were defined as neighboring census tracts having high number of syphilis counts with the MSM and CSW populations. Over the 10-year time period, a total of 3,853 syphilis cases were reported to the Baltimore City Health Department. And amongst these, about 57.57% were MSM and 6.93% belonged to the CSW population. As you can see here in the graph, there has been a significant increase in the number of MSM and CSW syphilis cases since the year 2015. Now, from the year 2009, there has been a 152.85% increase in the MSM population alone, and about 43.48% increase in the CSW population alone. It would be difficult to detect the presence of temporal clusters by using an epidemic curve alone. Hence, we thought it would be a good idea to use a software called as SAT-scan. Now, SAT-scan is a widely used cluster detection tool which detects disease clusters by using a scanning window. We used this tool to detect temporal clusters, and we found that between the years 2015 and 18, there were 2 statistically significant temporal clusters, one among the MSM population and second among the CSW population. Let us look at the spatial analysis. We investigated spatial trends at 1-year time intervals using a software called as ArcMap. Each map here describes the number of cases reported in a year and distribution of the cases by census tract. Our city of Baltimore has about 200 census tracts. As we can see here, there has been a gradual increase in the number of MSM syphilis cases since the year 2015. And the MSM epidemic seems to have originated in the center, radially progressing from the center to the outskirts. Now, the next 2 slides, we will see CSW case distribution spatially by 1-year intervals of time. For CSW, we observed fewer census tracts having high number of CSW syphilis cases over the 10-year time period. CSW cases seem to be more sparse and geographically random in nature, as we can see here in these graphs. If we examine the overlap among these 2 priority populations over the 10-year period, we can see that for the year 2016, there was 1 census tract here marked in red, which had high number of syphilis counts for both MSM and CSW populations. and our results are summarized on this slide. So far, we have been looking at the distribution of cases in space and time individually. Now let us move forward to spatiotemporal cluster analysis by census tract. Just to reiterate, a census tract was considered as having high number of MSM syphilis cases if it had 4 or more MSM syphilis cases in a year, or 3 or more such cases occurred between the years 2009 and 18. And similarly, a census tract was considered as having a high CSW counts if it had 3 or more syphilis cases in 1 year, and 3 or more such years occurred between 2009 and 18. In all, we had about 14 such census tracts which met the MSM high census tract case definition, and 2 for CSW. All of these are showcased on this particular slide. Due to the geographical proximity, we clubbed all of these 9 census tracts together and named it as MSM Cluster 1. These 5 MSM census tracts are geographically distant from one another. Hence, we named them as MSM outliers. And these 2 are CSW census tracts with high syphilis counts. Now let us dig deeper into each of these syphilis census tracts and see what the case distribution looks like by 1 year intervals of time. The area graph here shows us the case distribution by 1 year. We observed an increase in the number of syphilis cases in each of these census tracts, especially after the year 2015. Now, this increase may be the reason why we see an overall increase in the MSM cases in Baltimore City, both geographically and temporally. Even you can see here the number of cases are higher for 2015, after the year 2015. Whereas for CSW syphilis cases, the census tracts have more of a random occurrence of CSW cases and does not suggest a definitive trend in the occurrence of cases. To summarize, we identified 2 statistically significant temporal clusters between the years 2015 and 2018. Spatially at 1 year time intervals, we observed MSM syphilis cases spreading radially outwards from the center of the city to the neighboring regions, whereas CSW cases were more sparse and geographically random in nature. If we are to see the spatial analysis by a year, one census tract had high syphilis counts for both MSM and CSW in the year 2016, and no significant spatiotemporal clustering was observed between these 2 populations. Our analysis had various limitations, and few of them are as follows. First, we use SATscan as a cluster detection tool. Small clusters might have been obscured by larger ones. Second, there is a possibility that the true number of syphilis cases was never reported. Hence, our counts may be lower than expected. Third, stages of diagnosis depend on clinical symptoms observed and reported. A misclassification of these stages could induce a misclassification bias. To conclude, over the 10-year time period of the urban area of Baltimore City, we observed spatial patterns, significant clusters in time, and 1 overlapping census tract. Our results suggest that the MSM epidemic might have originated in the center of the city and might have spread radially outwards over time. These patterns and clusters can be used to inform targeted interventions to reduce the spread of syphilis in Baltimore City. Last but not the least, I would like to acknowledge timely support and expertise from our team members, our UShine team, our funding partners, and our public health partners. Without their assistance, the analysis would not have been possible. Thank you.